this morning I presented the results of PrECOG 0102, which was a randomized, double-blind, placebo-controlled trial of fulvestrant with or without Everolimus or placebo for the treatment of aromatase inhibitor-resistant metastatic breast cancer. Endocrine therapy is the mainstay treatment for hormone receptor-positive breast cancer, but inevitably resistance will develop. And we are all sort of struggling to understand what the next best therapies will be amongst a choice of an increasing number of options for our patients who have progressed typically on a non-steroidal aromatase inhibitor. And so our work has built on work that has come before, particularly examples like the Bolero-2 trial, which combined an mTOR inhibitor, Everolimus, with exemestane backbone. Exemestane is a steroidal-type aromatase inhibitor. So we know and are learning a lot about endocrine resistance and aromatase inhibitor resistance. One important pathway that appears to be aberrant and activated in this population and scenario is the PI3 kinase AKT mTOR pathway. And so our hypothesis was that by combining fulvestrant, which is a potent anti-estrogen in the class we call a selective estrogen receptor downregulator, with an mTOR inhibitor, that we would show superiority compared to, say, fulvestrant alone. A similar design to the Bolero-2 trial, where their anti-endocrine therapy backbone was exemestane in combination with the same mTOR inhibitor. Well, we were very pleased with the results. We found that the combination of Everolimus and fulvestrant more than doubled the progression-free survival to 10.4 months for the combination versus 5.1 months for single-agent fulvestrant or fulvestrant plus placebo. And the significance of the benefit appears to be very similar to the types of findings that have been reported earlier. For example, in Bolero-2, I think they improved the PFS from 3.2 months for exemestane to 7.8 months for the combination of exemestane and Everolimus. And so we had also similar types of findings, and we were very gratified by this. I think it's admittedly a small phase 2 study, only 130 patients, but the results appear very promising. They appear very consistent with the observations from other studies, and the toxicity of our study for the combination appears to be very consistent with the results of earlier clinical work. Right, so right now we are trying, I think, as a community in oncology to work out what the best combinations will be in different scenarios for women with hormone receptor positive breast cancer. So it appears now that a newer class of drugs, the cyclin-dependent kinase 4/6 inhibitors, are potent when combined with anti-estrogen backbones, both in the front line, initial treatment, and then maybe second line. Palbociclib is a compound that's approved here in the United States for frontline treatment of hormone receptor positive breast cancer in combination with letrozole, and it also has activity in the second line when combined with fulvestrant. On the other hand, the mTOR inhibitors may not be effective in the frontline therapy. There was a trial called the Horizon study that looked at an mTOR inhibitor, temsirolimus, and it was not effective in the frontline. And we think this may be because once progression on a non-steroidal aromatase inhibitor develops, we think that population may be enriched for mutations driven through aberrant signaling and the PI3 kinase AKT mTOR pathway. So it may be, in fact, better to use the mTOR inhibitor combination such as ours with fulvestrant, or maybe from Bolero-2 with exemestane, in the second line setting where you have a population that is so-called, quote-unquote, enriched for mutations within this pathway, sort of making them better suited for this particular type of medication. And so I think that opens up a kind of entree to this larger conversation, which is what is the optimal way to sequence these drugs and combinations of medications now that we have. It's sort of a good problem to have multiple choices, but can sometimes breed anxiety or it can be a little uncomfortable when we get worried or our patients are unsure what the best combinations are. But I think it's probably going to start to emerge maybe that the CDK4/6 inhibitors will move to the front line in combination with endocrine therapy, and maybe the mTOR inhibitors will be in the second line for, again, a population enriched for mutations in those pathways. So I think this morning we heard a really very excellent and amazing summary of the landscape of hormone receptor-positive breast cancer by Dr. Johnston, and he really very elegantly laid out sort of the state of the state where we are right now. And it's true, we have numbers of combinations, even from single drug treatments to combinations, newer combinations employing standard endocrine or anti-endocrine therapies with novel drugs of various classes, and the results are encouraging. I think we could imagine, even right now, optimally sequencing these drugs to have maybe close to 3 years of progression-free survival. And it is encouraging and exciting. On the other hand, if you have a young woman who has hormone receptor-positive breast cancer, it's hard to feel very excited about things like 3 years. So I think anytime we're talking about cancer that affects such a large percentage of patients, I want to caution myself from feeling excited to saying, yes, this is incrementally important and meaningful, but we have a lot of work to do, and we have to smile today and roll up our sleeves and go right back to the clinic and right back to our scientific partners in the bench, who we really are the unsung heroes of drug development, and work with our patients, ultimately the most courageous and heroic part of the whole thing, who we do it for, who inspire us and say, yes, we're excited to have incremental benefits, it's important, but we really have to soldier on and have a lot of work to keep doing.